Begin recording. Date is 26th December 2021. Unfortunately, working Boxing Day, but that is the price one must pay. So first patient was a 64-year-old female presenting at 9 AM for a first eye examination at practice. Patient is non-smoker, in good health, diagnosed with hypertension but under control with 2.5 milligrams of ramipril once per day. No known family ocular history. Chief complaint was of an irritable and unsightly fleshy mass located in the left eye conjunctival area, present for approximately 5 years. No associated visual complaints. Fleshy mass has appeared slightly red in this time. Other than slight foreign body irritability, no ocular pain is reported. Differential diagnosis consists of pingueculitis, pterygium, and less common diagnoses of papilloma, conjunctival carcinoma, conjunctival melanoma. Pause recording for sip of Nespresso Columbia with frothy milk and coconut sugar. Begin recording. Following examination, corrected acuities were right eye 6.6, left eye 6.7.5, with a refraction of right eye plus 1 dioptosphere, left eye plus 125 dioptosphere, minus 0.75 diopter cylinder at 150 degrees, and a reading addition of 2.25 diopters right and left, with N5 acuity each eye. Note irregular astigmatism in the left. Intraocular pressures at 9:15 AM using the Perkins tonometer were 14 millimeters of mercury in each eye. Oxybuprocaine anesthetic. Slit lamp examination of the right eye was unremarkable in relation to the chief complaint. Left eye, however, revealed a nasal pterygium, slightly red, of 1.5 millimeters corneal encroachment. This is the most likely cause of the patient's complaint due to the absence of the aforementioned differential diagnoses. Neither cornea displayed signs of staining with sodium fluorescein. Further ocular health revealed mild grade 1 lenticular nuclear sclerotic cataracts. Optic nerve head, maculae and fundi all unremarkable / within normal limits. CD ratio 0.4 right and left. In terms of management, patient reassured pterygium finding is not sinister and surgical intervention is not required at this stage. Furthermore, patient strongly encouraged to follow a strict regime of daily ocular lubricant use, ideally 4 times per day in the left eye, using a preservative-free product, in brackets, suggestions offered to the patient in terms of available artificial tears on the market, close bracket, full stop. Patient will be reviewed in 1 week following the management plan via telephone consultation. Recall will be in 2 years' time, but patient asked to contact the practice if worsening or new ocular symptoms develop. End of recording. Begin recording. Patient 2, 27-year-old male presenting at 9:30 AM with a 2-day history of photopsia in the right peripheral area of vision. On questioning, there has been a sudden increase in the size and quantity of visual floaters in the 2-day period. No reported physical trauma. Other than occasional long-standing floaters, these symptoms have never been experienced. No prior history of migraines or visual auras was reported. Visometry of spectacles reveals a highly myopic prescription of right eye -8 dioptosphere and left eye -9 dioptosphere. The patient has been wearing optical correction since the age of 8. Pupils were of equal size at 8 mm dim and 5 mm bright condition. Reactions to light were normal, as were the near constrictions in each eye, negative for RAPD. Pre-dilation IOPs using the Goldman tonometer at 9:40 am were right eye 13 mm of mercury, left eye 18 mm of mercury, noting difference of 5 mm of mercury. Bilateral dilation was conducted using 1% tropicamide, 2.5% phenylephrine each eye. Now the differential diagnoses consisted of vitreous detachment, retinal tear and retinal detachment. Visual migraines were considered but not suspected based on the nature of the symptoms. Slit lamp examination was conducted at 30 minutes of maximum pupil dilation. Right eye revealed signs of tobacco dust / Schaeffer's sign within the anterior vitreous. Furthermore, evaluation with the Volk superfield lens revealed a nasal horseshoe retinal tear located just above the horizontal midline. Left eye anterior and posterior chamber evaluation revealed no signs indicative of PVD, retinal tear or retinal detachment. Following immediate telephone conversation with the local eye hospital department, patient referred same day for ophthalmology attention in view of risk of right eye retinal detachment. Cover letter explaining ocular findings sent with patient to the eye hospital. Likelihood of retinal repair surgery / laser. Patient asked to return to the practice when receives the green light from the ophthalmologist. Okay, begin recording. Patient 3, seen at 10:30 am. 20-year-old female presented for routine eye examination following previous 2-year recall. No visual complaints, distance, intermediate or near distances. In brackets, note patient is a driver and works on a VDU 8 hours per day. End of brackets. No previous ocular correction. No hospital eye visits during a lifetime. Patient in good health. No medication taken. In terms of family, ocular history. Parental grandfather positive for primary open-angle glaucoma. For examination, vision was 6/6 right and left, planar prescription right and left, cover test distance and near, orthophoric, ocular health examination conducted with slit lamp, ocular adnexa clear, quiet and white, Van Herrick angles grade 4 temporally each side, negative for pigment dispersion or pseudo exfoliation. 60 diopter Volk assessment of optic nerve heads revealed non-glaucomatous looking appearance, pink defined and flat margins. CD ratio right 0.3, left 0.4, isn't rule appears obeyed. Maculae and fundi unremarkable. Opted for first time intraocular test using eye care rebound tonometer. Average reading right 17 mm of mercury, left eye 16 mm of mercury. Central screening perimetry examination full each eye and results excellent reliability. Happy to put patients on 2-year recall again, no further action required today. End of recording. Begin recording. Patient number 4, 73-year-old gentleman, seen at 11:30 a.m, presented with blurring and distortion of the left eye without pain. Covering of left eye reveals no noted visual changes to the right eye. Duration of symptoms approximately 3 days. No physical trauma. No noted double vision / diplopia. No changes to ocular floaters and no photopsia. Patient visited A&E approximately 20 years ago for inorganic foreign body removal, but unsure which eye occurred in. In terms of general health, patient is a type 2 diabetic. Most recent blood sugar checkup was okay, quote 7.2, close quote. Stable hypertensive. Mild rheumatoid arthritis, particularly affects hands and fingers. Current medication is metformin BID, ramipril OD, simvastatin OD. Additional supplements, patient takes cod liver oil and glucosamine. Differential diagnosis wide-ranging. Distortive symptoms suggest possible maculopathy, ? Diabetic maculopathy, ? Wet macular degeneration, ? Also consider corneal dystrophies, lenticular opacities, and maculopathy associated with vascular occlusive disorders. Examination. Corrected visual acuities were right eye 6/7.5, now changed from 8 months ago. Left eye down to 6/18, previously 6/7.5 8 months ago. Predilation intraocular pressures using Goldman in conjunction with 1% lidocaine were right eye 15 mm of mercury, left eye 14 mm of mercury. Anterior angles using Van Herrick's technique were grade 3 right and left on the temporal side. Slit lamp corneal evaluation reveals normal bilateral arcus senilius. No evidence of corneal infiltrates, edema or dystrophy either eye. Cross-section lenticular evaluation reveals no change in nuclear sclerotic cataracts at grade 1 each side. At this point, patient was dilated with 1% tropicamide each eye. Maximum dilation achieved after 25 minutes. But prior to dilation, right eye Amsler revealed no distortion or scotomas. Left eye Amsler reporting distortion of lines extending 4 squares to patient's temporal side, 3 squares to nasal side, 2 squares superiorly and inferiorly from central fixation spot. Volk lens examination post-dilation reveals no optic nerve abnormalities suggesting CRVO, BRVO, papilledema or ischemic optic neuropathies. Right eye macula, mild hard drusen but flat, no evidence of edema or hemorrhaging. Left eye examination to Volk lens reveals elevation at the macula, suspect subretinal hemorrhage at the macula with neovascular membrane. Therefore, diagnosis of left eye wet macular degeneration. Patient referral sent same day via the rapid access macular referral pathway to the local hospital. Explained findings to patient and highly likely possibility of left eye ocular injections to calm the macular activity in the left. Guarded prognosis in terms of visual recovery, if any at all. We'll telephone hospital later this afternoon to ensure referral has been received. End of recording.